Today's topic we are going to do choanal atresia. Choanal atresia. This is a congenital condition where we have the back of the nasal passage, that is the choanal, is blocked by either a membranous or a bony tissue, therefore preventing the airflow from the nose to the pharynx. So as you can see in the above image, this is our normal. So you are breathing well and you have no problem. This is the normal. Where you breathe in your hair, it passes through the turbinates and then it moves from the nasal cavity into the pharynx. Whereas in choanal atresia, you already have a blockage of the nasal cavity by the presence of the choanal. It could be either membranous or bony. So it's the most common congenital nasal anomaly, and it usually occurs in about 1 to 5,000 to 8,000 live births. It's most commonly in female than in males. So the embryology or the pathophysiology behind how we reach here is in our birth. Choanal opening is so already what is choanal opening. Choanal opening is the opening at the back of the nasal cavity that connects the nasal cavity and the pharynx. So in short, the nasal cavity and the pharynx. So it forms between the 5th and the 7 weeks of fetal development. So normally we have the oropharyngeal membrane that it recedes. So in our when we're in gestation period, we have this membrane, but usually it recedes and therefore allowing the continuity between the nasal cavity and the pharynx. So failure of receding of this membrane, therefore we have choanal atresia. So the obstruction could be bony 90%, it could be membranous 10%, or a combination of both. The types of choanal atresia, we have two. We have unilateral disease and we have bilateral disease. So unilateral disease, this is where it's more common and the ratio is 2 to 1. And this is often diagnosed until later, when later in childhood, because the baby can breathe using one nostril. So if the hair passes from the nasal cavity, it can go through the larynx, through the pharynx, through the nasal cavity. However, one of the nostril is not going to be used. This is how it's going to present. It's going to present as persistent unilateral nasal obstruction, and then the patient will present with chronic unilateral nasal discharge, because only this nose string can produce discharge. In addition to that, as we said before, it is usually diagnosed later in infancy or childhood. So bilateral, it's more severe and more life-threatening in neonates, and the reason behind this is because neonates are obligate nasal breathers. So this is unilateral, this is bilateral, meaning there is no passage of air from the nasal cavity to the pharynx. So neonates are obligate nasal breathers and they rely on nasal breathing. And if we have bilateral nasal choanal atresia, then you're going to have immediate respiratory distress. So how is this patient going to present? They're going to present with cyanosis that usually improves with crying. And the reason why it improves with crying is because when they are crying, their mouth is open, meaning the air that we breathe can pass through the mouth into the pharynx, since crying forces air through the mouth. And then the patient is also going to present with respiratory distress at birth, difficulty in breathing and choking, and nasal regurgitation, because when they're feeding, it's like they also want to breathe. So in addition to that, noisy breathing. So it's also associated with the charge syndrome. So should I charge you to go and tell me what the charge syndrome consists of? However, I can help you. So the charge meaning it's C for coloboma, that is high defects, H for heart defects, H for atresia of the choana, which we're already talking about, R for retardation of growth and development, G for genital abnormalities, and E for ear abnormalities and deafness. So you can also go and look and read about CHARGE syndrome. So the diagnosis, you can do clinical test, and obvious from the history, that's the first thing that you're going to do. You can also pass a nasogastric tube. That meaning you pass the tube from the nasal to the gastric. So if it fails to pass, then it is a suggestion that you have choanal atresia. In addition to that, you can also do fogging test. And fogging test is when you hold a cold metal in under the nose, and if only one nose fogs, then that means that we already have or it's a suggestive of choanal atresia. You can also do a cotton whip test, or you do imaging, and this is the gold standard for uh, gold standard for determining if a patient has choanal atresia. So CT scan with contrast. Where I said before, this is the gold standard. So as you can observe here, this is the nasal let me not start lying to you, but this is the nasal cavity. I'm just joking, and this is the pharynx. As you can see, there's a there's an obstruction in the two places, and you can observe this is bilateral choanal atresia. So it shows the location and the type of either it's bony or membranous atresia. You can also do nasal endoscopy, and this is direct visualization of the obstruction, and this is what is the nasal endoscopy. So management of this, already we have known that we have two types of choanal atresia, that is bilateral and unilateral. And we said bilateral is life-threatening. Meaning if it's life-threatening, then you have to do emergency management. So bilateral for atresia in unit, because we say they are what? They are what? Obligate nasal breathers. So the air always stabilize. It's you just use the ABCD. So the air we have is the airway, and already the airway has a problem. So airway stabilization is crucial. And then what do? You insert our oropharyngeal airway. Meaning, because we say this, when they cry, it kind of helps push the air into the pharynx. Then what we do, we just keep the mouth open, or keep the mouth open with an oral airway, that is MC Guven, nipple, or pacifier, with a hole to allow mouth opening, as you can see. So you are a clinician or you're a medical officer, and the child comes in with respiratory distress and cyanosis while crying. You maybe did a CT scan, or you maybe did the FOB test, and you are highly suggestive of bilateral choanal atresia. Then before you refer to ENT, you put the opening, you put an oropharyngeal airway. So in addition to that, you can also do endotracheal intubation for severe cases. Surgical treatment, these are mostly for the ENT, but you can also do a transnasal endoscopy puncture with stenting. Just like a small opening is made with endoscopy instrument, and then a stent is placed to prevent closure. So from the hole that we did, you just punch and then you place a stent. You can also do a transplantal approach. This is used for more complex and recurrent cases, but it is more invasive. You can also do a balloon dilatation. It is used in most cases instead of stenting. So pre-operative care, nasal saline irrigation to keep the passage clear. You can also use topical corticosteroid, and the reason behind this is to prevent edema. And if you prevent edema, in addition to reducing the immune, it also prevents scarring. You can also use regular follow-up with endoscopy to check if the patient has restenosis. So the key takeaway from this lecture, what we have learned, is you suspect choanal atresia in a newborn who comes in crying with cyanosis. Sorry, who comes in with cyanosis, and the cyanosis is revealed by crying. The reason behind this, we said neonates are obligate nasal breathers. So you use a catheter test to confirm, or to confirm a catheter test, and the gold standard is CT to confirm choanal atresia. It's an emergency treatment of the bilateral choanal atresia, and what we do, you ensure that you maintain the airway, and to maintain the airway by an oropharyngeal airway. Surgical correction is usually the definitive treatment for this, and for bilateral cases, especially for bilateral cases, you look out, or you watch out for charge syndrome in the affected individual.